Dear students, so welcome to this INICET PYQ series. I am Dr. Jazeer, your dermatology faculty at PW MedEd. So we'll be starting with our discussion about different questions that were asked previously in the INICET exam. So during this discussion, I have prepared almost 25 to 30 questions today, which we'll be discussing one by one, and you just can stop me and ask me any queries whenever you feel anything is doubtful. Okay, to start with, let's begin with the first question without wasting any time. So the first question is, which of the following is not associated with annular lesions? Now first, when you see this question, you can see it's a mention about an annular lesion. So what is a simple meaning of an annular lesion? An annular lesion means these are rounded lesions like this, right? So any rounded lesions, we call it as annular lesion. Now let's see the options now. The first option is Tinea corporis. The second one is Pityriasis Rosea. Third one is urticaria, and the last one is porokeratosis. So what is not associated is a question. Can anybody answer in the chat box? One of the answer that I can see is option D, that is porokeratosis. So do everyone agree with comment? Is it option D or something else? Let's go one by one. The first option is Tinea corporis. Tinea corporis, we usually call it as ringworm, right? So the name itself is a ringworm, which means it is going to come to you with an annular lesion. So that we can easily rule out. The second one is Pityriasis rosea. So what I can see is Dr. Ayush Shukla is answering it correct. So the correct answer should be Pityriasis rosea, because in Pityriasis rosea, we usually mention that there is something called as a herald patch, isn't it, or the mother patch, followed by there'll be small plaque lesions in the trunk, and these lesions, they will have a Christmas tree pattern of rash can be seen. Since the scaling is present towards the periphery of the lesions, we call it as peripheral scaling, or a collarette of scales, cigarette paper like scaling, right? And what else? So all these things are going to be the common findings in Pityriasis rosea. But in Pityriasis rosea, the textbooks have never mentioned that it is going to be an annular lesion. Okay. See, Herald, this first lesion, that is the mother patch, may be annular. It can be a round lesion. But all the other lesions, they are small plaque lesions like this. So there is no mention that these are rounded lesions. Okay. But what happens in all the others, like let us say the other options like in urticaria, they all get coalesced to form annular lesions. Porokeratosis, the patient will have multiple patch lesions in the body, which is also annular in shape. Out of all the options here, the best option should be a Pityriasis rosea. It should be a Pityriasis rosea. Just give me a minute. Just give a second. A minute. So now we will go to the next question, because I'm unable to see a chat. A minute. Yes. Now it's okay. So now let us see the next one. Match the following. So in INICET, it's very common to get this kind of a match the following, right? Like in the last exam, we got a match the following with a lot of signs, right? So now let's see this question. So in this question, patch test, KOH, biopsy, slit skin smear. So when you see all these options here, what you need to understand is that um, whenever you get a match the following, always try to go with the ones that you know. Let's say patch test. Where do you do a patch test? Patch test is usually done in a condition called as allergic contact dermatitis, right? So let us match A with A and 3. So now let's see the options. Which is the correct option? A3, we can see there are option A and option C. So I can easily rule out B and D, because I'm very confident that patch test is seen in allergic contact dermatitis, right? So A3 is the one that is left now. Now we are left with two more options. So let's see the second one. Where do you do a KOH mount? So where do you do a KOH mount? KOH test is done for, very good, yeah, fungal infections. So fungal infections, which one is the fungal infection? Leprosy, lupus vulgaris, contact dermatitis, tinea corporis. So obviously B goes for 4, right? So A3, B4 is correct. A3, B2 is wrong. So this probably should be the right answer. But still, let's check the remaining answers as well, remaining options as well. So the remaining option is biopsy. Where do you do a biopsy? We do a biopsy in lupus vulgaris, which is going to be the cutaneous tuberculosis. And where do you do a slit skin smear? We do that in leprosy. So C2 and D1. So that is all matching properly now. So this is going to be the right answer. I hope it is not difficult. Yes. So now let's continue with the next question. A hypopigmented patch which grows initially and stops progressing after some time is seen in which type of vitiligo? Now, focal, segmental, mixed and acrofacial. Matlab, all the options that you have got in this MCQ are different types of vitiligo. What do you think is the right answer? I'll just give you a second to answer in the chat box. So what is the right answer here? Just let me know in the chat box. Is it a focal vitiligo, segmental vitiligo, mixed type of vitiligo, or acrofacial, which will grow initially and stop progressing after some time? So here the right answer should be, yeah, it should be segmental vitiligo. Because in segmental vitiligo, very good Sanya. So in what happens in segmental vitiligo is the lesion in vitiligo is along a dermatomal distribution. It is along a dermatomal distribution. So once a lesion is along a dermatomal distribution, it is along a nerve root. That is why it do not cross the midline. It do not cross the midline, right? But along with that, you need to also understand that what happens in a patient who gets a segmental vitiligo is a lesion very small, let's say over the thorax. So a small lesion can grow bigger without crossing the midline. And once it becomes big and it becomes stable, it is not going to grow again. It's not going to worsen further, right? That is going to be called as a segmental type of a vitiligo. So Sanya was right in this question. That is, this one is going to be a segmental vitiligo. So now let's see the next one. A patient on anti-PD1 immunotherapy comes with pruritus, eczema, urticarial rashes. Histopathological examination reveals a subepidermal blister. The DIF of the lesions showed linear C3 and IgG on the basement membrane. So you can see that there in the DIF there is linear deposits of IgG and C3 over the basement membrane zone. What is the diagnosis now? The first part of the question may look something non-specific. Some patient is taking some immunotherapy, now comes with some itching, eczema, urticarial rashes. But see the second sentence, it is a subepidermal blister, which means the blister is forming under the epidermis. And the DIF, this is very specific because there is a linear pattern over the basement membrane zone. What is the answer? Is it pemphigus vulgaris? In pemphigus vulgaris, what is the finding in DIF? Can get a fish net pattern or a chicken wire pattern or a chicken wire pattern. So that is not going to be linear pattern, right? So it is not pemphigus. I can see Ashutosh, Ayush, comment, all of you are saying it is C. Are you sure it is C? Let's see the second one. What is seen in a bullous pemphigoid? In bullous pemphigoid, will you see a subepidermal blister? Yes, because the blister is happening in the basement membrane zone or the dermoepidermal junction, right? And what do you see in the DIF? You can see a linear deposits of Ig, G and C3 over the basement membrane zone, which is mentioned in this MCQ, right? But since many of you had said C, yeah, Maha is saying that it should be B. Yeah, B to 100% correct hai. But let's see if C is also correct, because this is INICET, right? So in dermatitis herpetiformis, what happens is, here you can see there is a granular IgA deposits at the dermal papilla, because here the problem lies in the dermis. So in the upper part of the dermis there will be some greenish fluorescence, and this is called as a granular IgA deposits at the dermal papilla. Okay, which means option C is not the correct answer, right? And what is option D? Pemphigus foliaceus. Can anybody tell me in the chat box, what do you expect in Pemphigus foliaceus? So what are you expecting in Pemphigus foliaceus in a DIF? Yeah, the DIF will once again show you a fish net or a chicken wire pattern. Fish net or a chicken wire pattern. So out of all these four options, what is the right answer? The right answer is a bullous pemphigoid. It's a bullous pemphigoid. Clear? So you can just feel free to ask me any queries if there is any doubt. Okay. So now let's go to the next question now. A 24-year-old male presented with asymptomatic scaly lesions over the back, symmetrical in distribution. Images of the lesion are given. Identify the disease and the pattern of the lesions. So these are the images that is given. So in the image you can see that there is some lesion that is seen here, and there is probably one more lesion that is also highlighted here. Now what is this? It's a 24-year-old young male. Anybody who can answer? Is it collarette scales, Christmas tree pattern, Pityriasis Rosea? Is it a Wickham striae that you can see in lichen planus? Is it a Christmas tree pattern in lichen planus? Or is it a worn-off ring in seborrheic dermatitis? So if you have gone through these topics, yeah, comment says the answer should be A. Yes, I completely agree, because you can see this is the Christmas tree pattern, right? You can see that the lesions are arranged in a Christmas tree pattern, and the collarette of scales that is seen in Pityriasis Rosea. The second one, that is Wickham striae in lichen planus, is not seen in this image, and Christmas tree pattern is not seen in lichen planus. It is seen in Pityriasis Rosea, and worn-off ring is not seen in seborrheic dermatitis, whereas worn-off ring is seen in psoriasis. It is seen in psoriasis. So Maha, Sanya, Ayush, all of you are getting this one right. So here the correct answer should be Pityriasis Rosea. So moving to the next question, there are two statements that is given. Typical INICET question, right? The statement 1 is the histopathological examination of a patient with a flaccid bulla and painful erosions showing suprabasal blister and inflammatory infiltrate in the blister cleft. That is one. The statement number 2 says the row of tombstone appearance is diagnostic of pemphigus vulgaris. Now the options are statement 1 is false and statement 2 is true. So first tell me, when you see these two kind of statements, first try to establish, is both the statement correct or wrong? What do you think? Is it correct? Are both the statement correct? Like, do you see a patient who is having a flaccid bulla and painful erosions, and this patient will be having a suprabasal bulla? Is it correct? Yes or no? Yes, because in a disease called pemphigus vulgaris, क्या होगा? The patient will have a oral mucosal erosions first. Followed by these oral mucosal erosions, the patient will come to you with a flaccid bulla, matlab a bulla which is so easy to break. And when you do a histopathology, you can see there is a suprabasal split. Suprabasal matlab above the stratum basal. That is what you can see, right? And yes, so Ayush is saying Maha, all of you are saying that it is all correct statements. And I can see in the chat box that yeah, so here both the statements are correct, which means we need to think about this and this now. Isn't it option C and option D? So let's see. We have ruled out this, we have ruled out this. Now, let's see. Both the statements are true, but 2 is not the conclusion of 1, but 2 is the conclusion of 1. See, actually what happens when there is a suprabasal blister? Because of the suprabasal splitting, the keratinocytes in the stratum basal, because of the split above this layer, the, the keratinocytes will also get separated from each other like this, which is called as the row of tombstone appearance, which is seen in pemphigus vulgaris, right? So the correct answer should be option D. The correct answer should be option D. Uh, Isn't acantholysis diagnostic for pemphigus vulgaris? Obviously, because what happens in pemphigus vulgaris as well as in pemphigus foliaceus, in both the cases there is acantholysis. Lysis matlab there is a separation of keratinocytes. In both the cases we can see there are many reasons for acantholysis. So Ashutosh, we can't say that this is the only reason why I say that this is going to be pemphigus vulgaris. If it is pemphigus vulgaris, there definitely will be acantholysis, which means there is a separation of keratinocytes because there is a desmosomal defect. Along with that, the second thing is that there will be a suprabasal split if it is pemphigus vulgaris. Because of the suprabasal split, there you can also see a row of tombstone appearance as well. A row of tombstone appearance as well, like what you can see in a graveyard. Clear? Chalo. Identify the following lines in dermatology: Hinderer lines, Marionette's line, relaxed skin tension lines, or Blaschko lines. And I can just zoom this image for you. So whenever I see this kind of an image, I always look for the pattern that you can see in the anterior and the posterior part of the chest, right? So if you are able to see this V-shaped pattern, what is this lesion or the lines most likely to be? Easy question, hai na? Yeah. So Ayush says it is going to be D, comet, petal and places. All of you are answering. Yeah, this is going to be the Blaschko lines. Okay. So what are Blaschko lines? Because several years ago, for the AIIMS exam, before we used to call it as INICET, we got a question that these Blaschko lines, they correspond to the development of what cell? Is it a keratinocyte? Is it a melanocyte? Is it a macrophage? Is it a mast cell? So what does this Blaschko line correspond to? Please remember they correspond to the development of keratinocytes. They correspond to the development of a keratinocytes. And also remember this Blaschko lines, whenever you see that a patient is having a lesion along a Blaschko line, usually क्या होता है, ये Blaschko lines जो है ये invisible lines होता है, invisible lines, and they become visible only in the cases of some diseases. जैसे you can remember the diseases like HIE. So for INICET, it is better you remember in which diseases can you see skin lesions over a Blaschko line. The first disease is called hypomelanosis of Ito, I for incontinentia pigmenti, and E for epidermal nevus. and E for epidermal nevus. Okay, 3 diseases. You can just remember as HIE. Okay, HIE. Hypomelanosis of ito, incontinentia pigmenti, and epidermal nevus. And remember, whenever the lesions will appear, they do not cross midline. They do not cross the midline. मतलब आज के जो डिस्कशन है, इस डिस्कशन में हमने डिस्कस किया कि देयर आर टू टाइप्स ऑफ लाइंस जहां पे द लीशन डू नॉट क्रॉस द मिड लाइन, isn't it? So one of them we have discussed a bit earlier. Let me just check, where did we discuss? Yeah, it is along the dermatomal distribution. So whenever the lesions are along a dermatome, it do not cross midline. Whenever the lesions are along a Blaschko line, also they do not cross the midline. So please remember these two lines where the lesions do not cross the midline. Clear? So now moving further, let's see the next question. Now once again, it's a match the following. Okay, we can see different diseases: erythrasma, pityriasis versicolor, tinea capitis, and vitiligo. On the other side, you can see different fluorescence: pink, white, yellow, blue, and coral red fluorescence. Now, what is this investigation that we are talking about? So, where do you get some colored fluorescence from the skin? Yeah, so this is going to be a Wood's lamp examination finding that the examiner is asking you, right? So, in this Wood's lamp examination finding, let's see one by one. Again, follow the same rule. If you know any Wood's lamp examination finding, then see those are matched properly or not. Let's say erythrasma. Erythrasma mein what is the color? In erythrasma, the color would be coral red fluorescence, right? So let's see 1E. So how many options do we have where there is 1E? So I can rule out A and I can rule out C. Now I'm left with two options, B and D. So 1E is done. Then what are you more confident about? Petals is saying option should be D. Let's see. So can you say pityriasis versicolor में क्या color होगा? या फिर easy thing is vitiligo. In vitiligo, what is the color in the skin? Depigmented skin lesions होता है, right? So depigmented मतलब white color lesions. And when you do a Wood's lamp, also you get a white color fluorescence. Let's match this. That is more easy. मतलब 4 is going to be B. So 1E 4B. 1E 4B. Now अब challenging हो गया. Now both these things are again correct. Now the deciding factor should be between pityriasis versicolor and tinea capitis. What is the color that you expect in pityriasis versicolor? Is it pink by any chance? No. And is it yellow by any chance? Yes. So pityriasis versicolor is going to be yellow. So let's see where is 2C going to match. यहाँ पे तो 2D हो गया. Blue color. We don't get a blue color in pityriasis versicolor, right? 2C is matching. And 3 is matching with D. That is tinea capitis is blue. So the correct answer should be D. So petals and places, you were absolutely right. Clear? So whenever you get a MCQ, the takeaway message is we don't know what they will ask you for the exam. But yes, when you get a match the following, the idea should be whatever you're confident of, just try to match them first. Rule out the ones which is not going to be correct and then try to match it as much as possible. Clear? So now going to the next one. Okay, PVY, that is how you remember petals and places. Pityriasis versicolor is yellow. Okay. Next is consider the causes of alopecia. Which among the following cause non-scarring alopecia? So which among the following is going to be non-scarring? So because we know that this condition called as alopecia or hair fall, hair loss, there are two types. It can be either non-scarring, which is more common, or it can be scarring, right? So now let's see what are the options given. Alopecia areata, telogen effluvium, androgenic alopecia, frontal fibrosing alopecia. So let me just give you a few seconds in the chat box to know if you can get this one right, because we have multiple options correct or just one? Let's see. Can you answer the chat box? Jessica, I can't even read. What is this? Yeah, yeah. Petals is saying option B, 1, 2, and 3. Okay. Maha is also saying it should be option B, 1, 2, and 3. Let me suppose you are right. Let me see the options now. Alopecia areata, telogen effluvium, androgenic alopecia, they are all non-scarring is what you say. Chalo, which means frontal fibrosing alopecia is going to be scarring. Correct? Yes, absolutely correct. So what I would always recommend in the classes is anything that starts with A or T, or even better, anything like ATA. It's another mnemonic that you can remember, is going to be non-scarring, like androgenic alopecia, alopecia areata, trichotillomania, trichotillomania, telogen effluvium, telogen effluvium, and anagen effluvium. Anagen effluvium. All these are common causes of hair loss, right? But see, everything starts with the letter A or the letter T. So remember ATA or A or T. It is going to be non-scarring. Whereas whatever are the other causes, like in scarring alopecia, there can be multiple causes. I'll just list down few causes so that you just have a quick revision now. This can be in lichen planus, like lichen planopilaris, or it can be in discoid lupus erythematosus, or it can be a fungal infection like chirion, pseudopelade, pseudopelade of Brock. So all these things are examples. Along with that, we have one more example. ये हो गया frontal fibrosing alopecia. Okay, frontal fibrosing alopecia. All these things are going to be examples of scarring alopecia. Clear? Does tinea capitis alone become cicatricial, or does it become cicatricial when there is chirion? A very good question, Ashutosh. See, remember that in tinea capitis, there are different types. जैसे black dot, grey patch, chirion, favus. Out of which this chirion and favus are inflammatory and black dot and grey patch are non-inflammatory. Where you can see a typical scarring alopecia is only in chirion. That is why I did not write tinea capitis. I just mentioned chirion. Please remember, every tinea capitis will never end up in a scarring alopecia. The specific type which will end up in a scarring alopecia is going to be chirion. Clear? After 2 to 3 weeks and telogen effluvium, yes, because telogen effluvium may take some time. That is why in one of the NEET PG exams, we got a question that why is a patient coming to you with hair fall after 2 to 3 months of COVID-19 infection? Because it may take some time and then you realize that there's a lot of hair shedding, that is called as telogen effluvium. Tinea type, favus and chirion. I'll just one moment. Yes, so if you just want, you can just note it down. Tinea capitis. We have 4 types. 1 is black dot, 2 is gray patch, 3 is chirion, and 4 is favus. Okay, black dot, gray patch, chirion, favus. Out of which chirion will lead to scarring alopecia. Clear? So these are the 4 types. Yeah. Please do mention syphilis as non-scarring or scarring. Very good. So you have done this topic well. So in syphilis, that is in secondary syphilis, you can see a moth-eaten type of an alopecia. That is also going to be a non-scarring type of an alopecia. Clear? Okay. So shall I proceed further? Is everything all right? Now let's go to the next one. You can see that a young male complains of a rash over his back, as you can see in this image. What is the most likely sign and diagnosis? ये तो repeat हो गया, right? Because we were dealing with PYQs, so all the questions that had come, which means it is also a hint that this is a topic that is frequently repeated for the exam, right? So you can, here you can see once again what the pattern that you should see. The moment you see this kind of an image is the Christmas tree pattern, which is again going to be Pityriasis Rosea. I'll just go to the next one. A overweight 12-year-old girl has the following black discoloration on her neck. What is this condition and what is its association? Maha is answering, it is option A. Let's go one by one. Acanthosis nigricans, insulin resistance, striae albicans, Cushing syndrome, Xeroderma pigmentosum, malignancy, cafe au lime spots, McCune-Albright syndrome. Obvious hai na? Yeah, that is why all of you are answering here. Answer is going to be A. Because this acanthosis nigricans, this is a condition where you get a velvety kind of a hyperpigmentation over the neck area. And if they ask you what is the most acanthosis nigricans, what is the most common association, then is it insulin resistance, is it PCOD, is it malignancy, is it obesity? What is the most common association? The most common association should be obesity. Along with obesity, you can remember there are multiple other causes as well, like metabolic syndrome, PCOD or PCOS. Rarely it can be associated with malignancies as well, right? Insulin resistance. So all those things are going to be the various reasons. Yes, that is about acanthosis nigricans. So now moving to the next one. A middle-aged Indian man came to your OPD with a lesion as shown in the image below. Now you can see there is a blurred image, but what I can see is there is a raised, rolled up edges for this lesion. And when you see this lesion closely in the center, you can see some red spot as well, right? So where do you find this kind of a lesion? For me, I can see several clues here. One is the site, this is the face, and on examination I can see it has a rolled up border, and in the center you can see central telangiectasia. That is a red color that you can see in this image, right? Face, rolled up border, central telangiectasia. Now what comes to your mind? Is it a squamous cell carcinoma, basal cell carcinoma, lupus vulgaris, or a nevus? Very good. So this is going to be a basal cell carcinoma. Yeah, Asutosh, I also completely agree with you, but please be careful, okay, when you learn these kind of tricks. Like if you draw a line in between the tip of your lips towards the earlobe, okay, the line above is going to be more common for BCC. At the same time, we also learn the line below may be common for SCC, but sometimes they may give it with a twist. Like let's say, if you got a similar image, but the question says, let's say the question says, the histopathological examination shows keratin pearls. If the question says the histopathological examination shows keratin pearls, what would be the answer? A lesion in the face. Anyone? Because the reason why I'm discussing this is the same image, the question may say that the histopathological examination shows peripheral palisading. So yes, that is a Ongren's line. Very correct, very correct. So if there is keratin pearls, the answer should be squamous cell carcinoma. Excellent. But if the question says the histopathology shows peripheral palisading, it should be basal cell carcinoma. Okay? So this is what we have seen in some of the recent exams. Like they may not give you a typical image like this, where you can see a rolled up border and a central telangiectasia. If it is a non-specific image, they may mention what is the histopathological finding. If the histopathological finding is a keratin pearl, please answer it as squamous cell. And if the histopathological finding is a peripheral palisading, please answer it as a basal cell carcinoma. Clear? Yeah. So now let's see the next question. A patient with several skin lesions undergoes an investigation and an image below. What is a test? Now see how the PYQs have changed time over time, right? So we were discussing about some vesiculobullous disease earlier. So in one of the exam, they went into way too basics. They asked you, what is this investigation that is done? And the image shows something like this. Now this is the image which we discussed a while ago. This is what we call as a fishnet pattern or the chicken wire pattern. Fishnet pattern or the chicken wire pattern. Okay, and what is this investigation? Yes, this is called as the DIF, that is direct immunofluorescence. It is mostly done in vesiculobullous diseases. Chalo, let's go to the next question. Just a minute. Yeah. So now the next question says, I hope my screen is visible. Yeah, a patient presents with vesicles and oral lesions. Histopathology shows suprabasal split again, right? So this is the image where you can see there is a split just above the stratum basale. So there is a suprabasal split. So in which disease did we mention that you can see a suprabasal split? Just a minute. Yeah, it's clear. Yeah. So all of you have answered it as Pemphigus vulgaris. So Pemphigus vulgaris would be the correct answer here. Sorry, some technical issues is there. So there is a small glitch with my screen. Just let me just see. Just give me a minute. Appearing with each movement. Okay. That is about a suprabasal split which can be seen with Pemphigus vulgaris. It can be seen with Pemphigus vulgaris. So now let's see one more. Now see, again, there was a PYQ in the INICET exam where you can see that the question that was asked was again going to be a match the following. But see how things have changed. Now it is all about the type of scaling. Mica-like scales, Collarette scales, Brany scales, silver scales. And they have tried to match it with some disease like psoriasis, Pityriasis rosea, Pityriasis versicolor, and Pityriasis lichenoides chronica. So what is the idea? We have to go based on what you know the best. What is the most easiest one? Silvery white scaling. Silvery white scaling is seen in psoriasis, right? So let's try to match 4 with A. So where do you get 4A? 4A. So I can see only one option. Probably this becomes very easy now, right? So let's see the other options. Where do you find collarette of scales? वो अभी हमने बात किया था. Collarette of scales or a cigarette paper like scaling or a peripheral scaling that is seen in Pityriasis rosea. So 2 is B. So correct, 2 is B. Brany scales. Where do you find Brany scales? Brany scales can be seen in Pityriasis versicolor. So 3 is C and 1 is D. Because this name I have done it last because Pityriasis lichenoides chronica. Maybe this is the one that you may not have done very commonly. So there you can find a Mica-like scales. So the correct answer should be option A. Very good. Maha, Petal, Sanya, Ayush, all of you are getting the correct answer. Okay, so now let me move to the next one. A patient presented with a single hypoanesthetic patch as well as a thickened peripheral nerve and a satellite lesion. How will the patient be treated? So what is the correct answer here? Do you want to go for a mono-drug therapy or a multi-drug therapy? पहले ये बोलो कि what happens? Tell me what is the diagnosis here? Is the diagnosis whenever a patient comes to you with a hypopigmented patch, which is having a sensory deficit. That is why we call it as hypoanesthetic patch, right? And there is a thickened peripheral nerve and a satellite lesion. So what could be the diagnosis here? Yes, the diagnosis here is leprosy. The diagnosis here is leprosy. And in leprosy, do you treat the patient with a single drug, mono drug, or multi-drug therapy? Yes, it should be multi-drug therapy. So easily I rule out these two options. Now I'm left with two options, either treat it with 6 months or 12 months. Now what is a differentiating feature here? The differentiating feature is not the single lesion, but even if there is an involvement of at least one nerve in leprosy, for how long do you treat the patient? You treat the patient for 12 months. You treat the patient for 12 months. So please remember, because what we do is we usually are going to divide leprosy into either a paucibacillary or a multibacillary. Multibacillary, right? So when we divide this leprosy into two types, pauci or multibacillary, we are going to count the number of lesion. If the lesion is 1 to 5, let's call it paucibacillary. If it is more than 5, let's call it as multibacillary. So in our MCQ, it was only a single lesion. Then you must be thinking कि paucibacillary होगा. But when you check for the nerve, there is no nerve involvement in paucibacillary and at least one nerve involvement when it comes to multibacillary. And the skin slit smear may be negative here and the skin slit smear would be positive here. So just see the question once again. Now because of the involvement of at least one nerve, we have to treat it as multibacillary, and for multibacillary the treatment is always 12 months of MDT. Whereas for paucibacillary, it can be 6 months of multi-drug therapy. So in pemphigus foliaceus, the split is subcorneal. Means the top layers here was just above basal layer. The last question, why not pemphigus foliaceus? So okay, if the answer for this question is clear to all of you, I'll just go back and clarify the doubt in this question. Okay, so here what happens is the question is saying that the patient is having a suprabasal split. So what do you mean by suprabasal, which means above the stratum basale? What layer is coming above the stratum basale? It is going to be the stratum spinosum. So in which disease do you have a split in the stratum spinosum? That is pemphigus vulgaris. So your doubt was about pemphigus foliaceus. In pemphigus foliaceus, the split will be subcorneal split. So when it is below the stratum corneum, which layer comes under the stratum corneum? It should be the stratum granulosum. So if the MCQ had given an image where there is a split in the stratum granulosum, or if it had mentioned as subcorneal split, then the answer could have been pemphigus foliaceus. But since it is mentioned as suprabasal split, that which means stratum spinosum is where you can find the split, then the answer should be pemphigus vulgaris. Okay, done. Okay. So now let's go further. Yes. So now going further to the next MCQ. For a pregnant woman taking leprosy treatment who developed type 2 leprosy reaction, what is the best treatment? Thalidomide, azathioprine, stop the treatment and give steroids, continue the multi-drug therapy and add steroids. So now the thing is that you need to imagine the patient is a pregnant female, but she is already having leprosy. Isiलिए she is having a leprosy reaction, right? So here what do you see? What is the best treatment? So Petals and Places says D, continue multi-drug therapy and add steroids, right? So do all of you agree? Yes. So Sanya is also answering it as D. Yes. So please remember, when it comes to any question about lepra reaction, be it lepra 1 or lepra 2 reaction, in both the cases, your treatment remains the same. You always have to continue on multi-drug therapy and start prednisolone. Prednisolone. So this prednisolone, what is prednisolone? It's a systemic steroid. So this would be the correct answer. Tell me, do we use thalidomide in any type of lepra reaction? Like, do we use it in type 1 or type 2 lepra reaction? Thalidomide. Remember, thalidomide is used in lepra 2 reaction. But thalidomide has a problem. It has a problem like teratogenicity, that the babies may be born with some birth defects. So since because of the problem of this teratogenicity, we never use thalidomide in a pregnant female, right? So that is why our treatment here would be with steroids. Would be with steroids. Yes, type 1 is type 4 hypersensitivity and type 2 lepra reaction is type 3 hypersensitivity. Excellent. So the visual vital wisdom says sealed limbs. Yes, teratogenicity is sealed limbs. It's also called as the phocomelia. So baby may be born with sealed limbs after taking thalidomide. Excellent. So happy to get all these answers in the chat box. So now let's see the next question. A 10-year-old boy is bought with weakness of his lower limbs and a rash over the eyelids. The biopsy shows inflammation of the muscle. What is the finding shown in the image below? So there is some muscle weakness and there is a rash over the eyelids as well. First, before we even comment on anything, when you see all these things together, is there any diagnosis that comes to your mind? Yeah, I know all of you are giving the answers in the chat box, but yeah, very good. Petals and Places. It should be dermatomyositis. है ना? So the diagnosis here is dermatomyositis because the patient is having muscle weakness. This rash around the eyelids, this is what we call as a heliotrope rash. It resembles a heliotrope flower. That is why we call it as a heliotrope rash. So when you see this image, in this image, you can see that there is a rash over the knuckles. There is a rash over the joints, but the area between the joints is all spared, right? So this kind of a rash is called as a Gottron's papule. Okay, it's called as a Gottron's papules. So the other option, Scholl sign, is also seen in dermatomyositis. Scleroderma is a disease, a separate disease by itself. Heliotrope rash is what you can see around the eyelids. So here the correct answer should be Gottron's papules. So let me move further. Yeah. So the next question is, a diabetic patient presents with the following lesion over the armpit. Which of the following would be seen on a Woods lamp examination? Now just see this image. You can see that there is a hyperpigmented lesion over the axilla and the patient is diabetic here. Now, what are you expecting? Yellow, coral red, green, or blue? So we'll try to match what is most likely possible. The most likely one. Anyone in the chat box? Just giving you a few seconds for you to answer. The clue is axilla, hyperpigmentation. The visual vital wisdom says B. Sanya all says B. Yes. So this should be coral red fluorescence, because here the spot diagnosis is erythrasma. And what is the causative in erythrasma? Is it streptococcus, staphylococcus, pseudomonas, or something else? Something else. What is this? It's going to be something that is present in all of our body. It's a part of a normal flora bacteria. It's called as Corynebacterium. Okay, Corynebacterium minutissimum. It could be the causative of this condition called as erythrasma. Excellent. Very good. So now let me move to the next one. A 60-year-old patient presents with a lesion that is given in the image below. He also describes having a sensation of a spiders crawling in the area of the lesion when he woke up. Which of the following is the most likely diagnosis? You can see this image also. Some red color is there. So over this erythematous lesion, there are some, actually it looks like a bullous lesion here, but usually it presents with a vesicular lesion. So some vesicles on an erythematous background. Yes, answer is herpes zoster infection. So herpes zoster, this zoster infection is usually because of reactivation of the varicella virus. So today during our discussion, we already discussed about one condition जहाँ पे dermatomal distribution होगा, which will not cross the midline. What was that? Segmental vitiligo. This is the second condition which is along a dermatomal distribution. It's called as herpes zoster. And please remember, the patient of a herpes zoster, even though this is the reactivation of chickenpox or the varicella virus, but still please remember that the complaint of the patient is never the rash. The complaint will be the burning sensation, and probably this burning sensation, some patients may feel it like a spider crawling like feeling in the area of the lesion, right? So this is what we call as herpes zoster. What about herpes simplex? See, herpes simplex may, please remember, there is no dermatomal distribution. In herpes simplex, there will be a red color background. There will be some vesicles over the rash, but never along a dermatomal. Dermatomal matlab herpes zoster. It is going to be herpes zoster. Yeah. Most common is thoracic dermatome. Exactly. This image, if it is a thorax, is the most common site. And yes, as you have rightly mentioned, in all these patients, the most common complication is actually the persistence of this burning sensation even after the lesions have disappeared. This most common complication is called as post herpetic neuralgia. It's called as the post herpetic neuralgia. So in this case, can you also tell me कि if a patient is having herpes zoster और आपने ट्रीटमेंट किया, क्योंकि ये varicella virus infection है, जैसे चिकन पॉक्स में ट्रीटमेंट किया था, the same treatment we give like acyclovir. After giving acyclovir, the patient, the rashes will subside. पर patient आपके पास वापस आ रहा है ये बोल के कि burning sensation still persistent, is going to still persist. So in such cases, what is your treatment going to be? Are you going to give acyclovir again or give some other drug? Yeah, it should be gabapentin. Okay. The treatment should be gabapentin. The visual vital wisdom. I don't know what is your real name, but according to me, the best choice should be a gabapentin, even if gabapentin and carbamazepine both are given in the options. Okay. Thank you. So now let's go to the next one. A child presented with asymptomatic lesions on the forearm and on the shaft of the penis. The lesions on the forearm are shown below. So this is a lesion in the forearm. Matlab, there are a lot of skin colored papules over the forearm. The moment we see a skin colored papules over the forearm in a child, we think about another differential diagnosis which is called as phrinoderma, which is usually associated with many vitamin deficiencies. They say vitamin A, B, C, even free fatty acid deficiency. But when you see the options, in the options में क्या लिखा है? Lichen planus, lichen nitidus, scabies, and scrophulodema. So here the capsaicin is only for the pain. It's not a treatment as such. Okay, for the pain relief, yes, we can use, but for the treatment, it should be gabapentin, capitals and places. Yeah, so here it is not vitamin deficiency, it is not phrinoderma, but this is another condition called lichen nitidus, which will also present very typically with these lesions over the elbow region. Okay, somewhere here, multiple papules like this, what you can see in this image, and multiple small papules like this over the shaft of penis as well. Okay, so when I talk about lichen nitidus, let me also write down the histopathological finding of lichen nitidus, because this condition has a very typical histopathological finding, because it looks something like this. Okay, imagine it's a ball and it is my claw. Okay, the claw clutching the ball appearance can be seen. Okay, claw clutching the ball appearance can be seen in the histopathology of a lichen nitidus. Excellent. So you know about claw clutching the ball appearance as well, which means that your preparations are going well on track. Excellent. So now let's see the next question. Which of the following does not indicate a syndromic approach to treating sexually transmitted infections in males? So we know that you must have learned about the color coded kits, right? The green kit, the gray kit and all. So here what do? It's a syndromic management. Based on the symptoms of the patient, we are going to treat the patient with some color coded kits. But tell me, what is not applicable in males? Genital discharge is applicable, right? Lower abdominal pain, urethral discharge, inguinal swelling. Yes, all of you are answering it as B, and I completely agree with you. It should be the lower abdominal pain, because this lower abdominal pain is usually associated with females. And what is this lower abdominal pain commonly associated with? Yeah, it can be dysuria, it can be urethritis, all those things, but again, it should be specifically PID, right? Pelvic inflammatory disease. Excellent. So Renu, Sanya, all of you, Petals, all of you are answering it correct. So it's option B. So now once again, see, now you know that for the upcoming exam, what is the thing that you need to prepare? You need to be prepared for a match the following type of a question. Sometimes signs, sometimes fluorescence, sometimes clinical signs, isn't it? So we saw some scaling also earlier, which means all these are previous year questions. So please try to go with the pattern. So now when you see about the signs, let's do the same thing. Where do you see an auspit sign? Easy, enough. So auspit sign is going to be seen in psoriasis. So let's see 1D. Let's see 1D. Here it is 1D, 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 which means we can only rule out one option. Second one, carpet tack sign. Where do you see a carpet tack sign? Anyone? Okay, I'm already getting answers. Everybody's saying B, 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 B. Let's see. Carpet tack sign is seen in discoid lupus erythematosus. So 2B is correct, 2C is wrong, 2C is wrong. So now we have an option that is option B. But still, let's confirm the remaining options as well. 3C, Darrier sign mastocytosis. Correct? Yes. Darrier sign is seen in Urticaria pigmentosa. Urticaria pigmentosa. And this Urticaria pigmentosa is cutaneous mastocytosis Darrier sign. And flag sign is seen in kwashiorkor. That is in the hair. Right? Yeah. Yeah, due to the follicular plugging, you can see carpet sign in DLE. That is about this question. The answer should be option B. Next one. A 30-year-old man complained of pigmented lesion on the palms and soles. He also gave a history of sexual contact and a transient genital lesion 1 month ago. Which of the following test is appropriate for him? Zanxmia, serological test, KOH mount, biopsy. Now, what is the patient having? He is having some hyperpigmented lesions in the palms. Okay, so there are pigmented lesions over the palms and soles. There was a history of a genital lesion 1 month ago, and there is some history of a sexual contact as well, which means we are talking about some STI, sexually transmitted infection. What is the sexually transmitted infection? Yeah, I can see. Okay, just remind me by the end of the session. I shall explain about it. Okay. Yes, very good. We are talking about syphilis. But tell me, primary syphilis means you have a genital ulcer disease, right? But here you have some lesions in the skin as well. So whenever skin manifestations are present, the diagnosis becomes secondary syphilis. Correct? In secondary syphilis, will you go for a dark field microscopy or will you go for antibody testing? Obviously, you have to go for antibody testing, right? So here you can go for antibody testing. So you can go for something called as FTA, ABS, even a VDRL can be done, TPHA can be done, TRUST can be done. So all this comes under the antibody testing for syphilis. So now let's come back to the option. Zanxmia, serological test, KOH mount, biopsy. Now what's the answer? Yes, very good. The answer should be serological testing. At the same time, please remember, don't make mistake on the day of the exam. If it is primary syphilis, then the diagnosis should be with a dark field microscopy. Because in a dark field microscopy, what do you see? You can usually see a what type of a motility? What is this? Corkscrew motility. Right? You can see a corkscrew motility of Treponema pallidum in a dark field microscopy. So that is all about this short discussion about different diseases. Different MCQs that has come in the previous years in the INICET. Okay. So somebody was asking, syphilis rule out कैसे किए? So see, when you talk about syphilis, मैंने क्या किया? मैंने बोला कि अगर primary syphilis है, primary syphilis will always present to you with a genital ulcer or a extra genital ulcer. मतलब यहाँ पे क्या होगा? Ulceration होगा. Maybe a ulcer in the genitals or a ulceration over the lips, जो हो गया extra genital ulcer. But if the patient is having a secondary syphilis, here we don't have an ulcer anymore. The ulcer must have healed. यहाँ पे the patient will have a lot of skin lesions. जैसे हो गया that lesion over the palms and soles. Sometimes there can be lesions like condyloma lata, right? So all those things are skin lesions, mucosal lesions होगा. इसके साथ एक generalized lymphadenopathy भी होगा. Generalized lymphadenopathy. But what happens in a primary syphilis? Here you have a inguinal lymphadenopathy. So in primary syphilis, the lymphadenopathy is limited to the inguinal region, and in secondary syphilis, the lymphadenopathy becomes a generalized lymphadenopathy and a lot of skin lesions. So because of the skin lesions, that is why the patient usually comes to the dermatology OPD, not an internal medicine OPD. Yes. So on your special request, petals and places, Darier's disease. So this Darier disease is what you wanted to know. So this is considered to be an inherited vesiculobullous disease, where it is going to be autosomal dominant in inheritance. Okay? So what happens here is a patient, easy way to remember is, the easy way to remember is that uh, the patient will come to you with a dirty, warty, malodorous lesions. Dirty, warty, malodorous lesions will be present over the seborrheic sites. Over the seborrheic sites. Dirty, warty, malodorous. Dirty matlab kya hai? It does not look good, right? Warty matlab it does not feel good. So if you just try to palpate, वो काफी rough surfaced होगा, इसीलिए warty lesions, and it does not smell good. So diarrhea is easy हो गया, does not look good, does not smell good, does not feel good, हो गया diarrhea's disease. And this diarrhea's disease, remember D for D. Matlab in diarrheas, in the histopathological examination, you can see dyskeratosis. So there is a premature keratinization of the skin. So this is called as dyskeratosis. And diarrheas, you can treat the patient with something like a isotretinoin. Isotretinoin. One more live session in the coming days. No problem. I guess we have back-to-back sessions. Can you touch upon the biologicals? Okay. So let's see some of the biological agents. See, biological agents, they are used in various diseases in dermatology. Let's say that a patient who is having recurrent urticaria, and this urticaria is not getting settled with antihistamines or with steroids. So in urticaria, what is the biological agent that can be used? Anyone? Can anybody answer in the chat box? Like steroids use किया, antihistamines use किया, but फिर भी you're not getting a proper control of the urticaria. So in urticaria, you can go for omalizumab, which is a biological agent that is being used. Okay? And when it comes to some conditions like pemphigus vulgaris, what is the biological agent that is used in pemphigus vulgaris? Any idea? So in pemphigus vulgaris, we can go for rituximab. Can go for rituximab. Very good. And let's say one more disease, one very important disease, that is going to be, let's say, psoriasis. Psoriasis. So in psoriasis, there are a lot of biological agents that is being used. So some of the biological agents, what you can remember is, you can go for ustekinumab, secukinumab, apremilast, and how do you remember is with a mnemonic USA. Okay, ustekinumab, secukinumab, apremilast. All these things USA. There is again more, like you can remember it as AEI, like alifacept is there, isn't it? So many other biological agents can also be used, but at least a few biological agents for you to remember. We were having one patient on rituximab. Excellent. Very good. So that is it. So do you want me to touch any other case or any other topic? I'll be happy to do that. I'll just give you a few more minutes. So the way all of you were interacting today was amazing. That is the reason why we were able to touch many more other topics as well. So yeah. So if there is no more things, definitely we'll have more live sessions coming up in the coming days. And please prepare well. And I wish you all the very best for your upcoming exams. Yeah, wishing you all the very best. Thank you so much for being a very interactive crowd today.